Well, I actually want to say thank you to everyone in LOCOMOTION, but it's not just in LOCOMOTION. I think people who are working in long COVID clinics for us and who are researching for us as well. It goes without, it shouldn't go without saying really, but I am thanking you on behalf of the patients. So I also know that it's like facing a tide of demand, and as clinicians, that's really difficult. But we do appreciate it. So I'm just going to briefly skim over what were things like in the long COVID world 2 years ago and what they were now. I was reminded the other day that the clinics were funded just for assessment, actually, which is a very key thing. But that actually, people have been doing a lot more in clinics than that. What were patients like in 2021? Basically thinking it wouldn't last too much longer. And I guess a wing and a prayer wasn't really good enough. And the reality is that many years later, well, over 3 years for many people, there's a lot of people still not recovered. And I think we have an issue of those people who are coming through with a newer form of illness, and then people who've had it longer, and there's something different about that. I'm not going to read through all that, but just to say there was a recent study which was quite interesting. It looked at the impact of fatigue. I think it was from Exeter or that way, and they looked at the impact of fatigue and estimated that it was greater than having a stroke and comparable to Parkinson's disease, with health-related quality of life lower than some advanced cancers. So I think we do need some sort of pathway for people who've been in this for 3 years, because I think that the complications are different, and one of the emerging things is some of the cardiac risk factors, amongst other things. 2 years ago, we noticed that there was something that changed around about the 3 months time period after people had COVID. And I think something happens then for many people, and recent studies are showing that actually if you get to the 3-month point and you're still very symptomatic, that you're likely to continue with that, and it's more likely if it's the wild type of virus. What do we understand then and now? I think the ideas on possible mechanisms have not really changed in this time. And we know that not everybody has the same combination of problems, that it can be quite an individual impact. But I think what we now know is that the virus is adept at entering blood vessels, epithelium, and so it has vascular effects all over the body. One key point I'd like to make here is that even if people have had symptoms for 3 years, it's still worth starting symptomatic treatment for things like the autonomic dysfunction. It can be quite responsive quite quickly, and people have gone from not being able to work to being able to go back to work, and similar improvements in function. So I think it's worth a shot, at the very least, to start things like treatment for autonomic dysfunction if people have that. I think some of what we see is new. It has its own surprises, this virus. But I think there were a lot of theories about what viruses in general could do and what problems they could cause even before COVID. For me, I think we are seeing how this, confirming really some of the pathological effects of viruses in general, and potentially how some autoimmune diseases form. So I think there's been quite a pace of knowledge. I put the pictures of the sea there because one of our members has in mind that 3 years on, it's like a long, long, long tide having gone out. And when the tide goes right out, you see all these rocks and other things that are left there. So I think, again, with the longer term illness, things are being revealed now that we need to maybe reevaluate as people go along. Not turned up. That picture was going to be king.
It was there.
Oh, God, I had a picture of this beautiful little frog, right? Because there's a lot of speech slips in long COVID, some quite specific speech problems. And we were talking about brain fog, but we said brain frog the other day, and we just thought, well, that sums it all up. I think a lot of us have talked a lot about the brain dysfunction, and I think we really need to think in the country about some of the cases perhaps that might have had an encephalitic sort of fragmentation or may have developed problems since. There's been a really good paper out last week by a professor of linguistics called Professor Louise Cummings in Hong Kong. She's done extensive work on neuropsychological testing over the 3 years. And what's really interesting, she's narrowed down what some of the speech pattern disorders are. This is not stuff I knew about before last week, but after her research, she says there's 2 categories you can put speech problems in, either primary speech problems like aphasia or cognitive communication disorders. And so treatment-wise, that's how it needs to be approached, and specifically with speech therapy. I think that's a really important new thing that helps direct some of the therapies. Speech problems are just so common, and voice problems, distinct things, and I think those impact a lot of people at work. Cardiac issues. We knew that there were around about 20% of people had myocarditis then, and it's been confirmed by the Stimulate trial and UCLH. Well, I think it was Stimulate, but certainly it's from UCLH. I worked on the WHO rehabilitation guidelines for long COVID, and they have done a huge literature research, and there's a strong evidence base to exclude the red flags. And I think I certainly didn't know about post-exertional symptom exacerbation before this project. And I think a lot of us are now much more aware of that as something to rule out and manage in people. And to be careful, very careful with their responses to exertion. I'm just very briefly going to talk about some of the big picture. The terrain out there is that there's government funding changes, and that's going to be potentially a barrier to how clinics run and so on. The economic impact of the number of people who are off work with long COVID is large, and all the surveys are showing similar figures. And in fact, our own economics work package here showing that approximately 50% of our sample are on reduced work capacity, meaning they've lost their job or reduced their hours. So, yeah, we've mentioned research into treatments, and these are comments that reflect the whole UK, not LOCOMOTION. We've got to prevent people getting long COVID, and you prevent it by people getting COVID in the first place. And this is still a category 3 virus, which is a pretty high hazard virus. It's still a notifiable disease, yet all precautions have been taken away both in workplaces and for the vulnerable. And along with that, I want to say that, again, there's a graph missing, but reinfections significantly increase everybody's risk. And the graph is really quite visual because it shows you exponential increase in complications if you've had 3 infections. So it's going to affect everybody if we don't